Good afternoon and welcome to the DCRI Research Conference. I'm pleased that many of you found your way to 7015. For those of you that went downstairs and you saw that hard hats were required and you were trying to understand what that had to do with today's presentation, it has nothing to do with it. So we're just redoing downstairs for the purpose of streaming and archiving, and from what I hear, it's going to be incredible in terms of resolution for slides and for our presenters. So I am pleased that you've been able to join us today, and we have two very special speakers, and we are going to save some time at the end of the presentations for both Akshay and for Connie to say a little bit about the cardiology as well as the DCRI Research Fellow experience, which is obviously something that we feel very strongly about as mentors and as people that work and create at the DCRI. Akshay Bagai is one of our chief fellows here at the DCRI this year, completed his training at the University of Toronto, and now will be returning to St. Michael's in Toronto to join the group there. Will be very active in the Vigor group that many of you know very, very well, that we've interfaced with for decades now and done some great work together. Connie Hess will also be presenting today. Connie has come through the Harvard system before joining us here at Duke, and will be staying at Duke for an interventional cardiology fellowship. So they will each have 15 or 20 minutes to give a presentation. You can ask your questions at the end, and then, as I mentioned, they will both come up and say a little bit about the DCRI Research Fellowship experience. Akshay is going to discuss his work in bypassing the emergency department for acute myocardial infarction, feasibility, safety, and efficacy. And then Connie will discuss her work with the relationship of early physician follow-up and 30-day readmission after non-ST segment elevation myocardial infarction among older patients. So Akshay and Connie, thank you for joining us today. Okay. We'll work through that.
I'm sorry to tell everyone there are no speakers in this room. The microphones you see everyone using are for recording, not for room reinforcement.
I'll try to speak louder.
Thank you.
Nancy, is that better? Okay. Well, thank you, Dr. Becker, for the introduction. It's a pleasure to be here with you all today. And the topic of my presentation is emergency department bypass for patients with ST segment elevation myocardial infarction, feasibility, safety, and efficacy. This is a project that I worked on for the last 2 years here at the DCRI, and I'd like to share my findings with you. So the audience is well aware that in patients with ST segment elevation myocardial infarction, faster reperfusion is associated with lower morbidity and mortality. The national guidelines recommend that device activation should occur within 90 minutes of first medical contact. However, recent data in the United States has shown that timely reperfusion still remains suboptimal. The national guidelines have a number of strategies that are recommended to optimize reperfusion. First is to be able to do a 12-lead electrocardiogram at the site where the patient experiences chest pain. And I'll show you data that again is a problem in the United States. Second, once the ECG is done at the site, the paramedics have to recognize that this is an acute myocardial infarction and then have a protocol in place to make a decision where to take this patient for intervention. Studies have shown that patients with ST elevation myocardial infarction, if they can achieve timely reperfusion with primary PCI within 90 minutes, they should have PCI rather than thrombolytic therapy. If at the site a diagnosis of ST segment elevation is made and a non-PCI hospital is closer by, the recommendations from the guidelines is that if you can achieve device activation within 90 minutes, you should bypass the non-PCI hospital and take the patient directly to a PCI hospital. We will see data on this that majority of the patients are taken to the emergency department of the PCI hospital first, evaluated there, and then taken to the lab where the treatment is instituted and the artery is opened. Along the spectrum, the European guidelines have actually recommended not just to take them to the primary PCI hospital, but to in fact bypass the emergency department in the primary PCI hospital. So they recommend, instead of actually stopping over and getting evaluated, to go directly to the cath lab. Now, this is a big change in paradigm, shift in paradigm in the United States to even consider this, because in patients who have ST elevation myocardial infarction, they can decompensate and they can get sick. There's also medical legal issues in regards to there should be an emergency doctor who should evaluate these patients first before they undergo treatment by the interventionalist. This recommendation was not therefore endorsed in the updated 2013 American College of Cardiology guidelines, but as I said, it's endorsed in the European guidelines. And me coming from Canada, we've been doing this for the last 5 years, which is bypassing the emergency department. Therefore, my study objectives were as follows. Among patients who were diagnosed with STEMI pre-hospital, we first wanted to evaluate what is the proportion of patients in the United States that are transported directly to the cath lab, from here on called ED bypass group, versus the proportion of patients that are triaged and evaluated in the emergency department prior to transport to the cath lab, called the ED evaluation group. We wanted to assess whether bypassing the emergency department was associated with faster reperfusion. And lastly, we wanted to investigate whether bypassing the emergency department had any impact on lowering mortality. For this study, we used data from the Action Get With the Guidelines National Registry, which is a national registry of acute coronary syndrome patients. Our study period was from July 2008 to March 2011. And during this time period, 61,000 patients had ST elevation myocardial infarction that was treated with primary PCI. We excluded those patients who did not have a pre-hospital electrocardiogram, and we excluded those patients who arrived first at a non-PCI hospital, as we were only interested in the patients who had a pre-hospital electrocardiogram, had the diagnosis of STEMI, and were taken directly to a PCI hospital. Among these 17,000 patients, another 2,000 patients did not have ST elevation on their first ECG and only developed ST elevation on their second or third or fourth subsequent ECG. Therefore, our analysis cohort was 12,581 patients who were treated with primary PCI at 371 hospitals, and they were identified with STEMI on their first pre-hospital ECG and taken directly to a PCI center. We compared patients who were evaluated in the ED first before going to the cath lab and those patients who went directly to the cath lab. We studied the timing of reperfusion as well as in-hospital mortality, both unadjusted and adjusted. And we also did a sensitivity analysis after excluding higher risk patients, those patients who had heart failure or shock or cardiac arrest or intubation, where most doctors feel that these patients should go first to the emergency department to be resuscitated and stabilized before they go to the cath lab. Although, again, that's not universal, but certainly that's a concern regarding these high-risk patients. Following our results. This graph shows a temporal trend over the 4 years of the study. The three lines that are highlighted are the use of EMS, the use of pre-hospital ECG, and the use of ED bypass, which was the major study. So, considering the use of EMS, which is essential to be able to bypass the ED, it's seen that over the 4-year period, only 50% of patients who have primary PCI for STEMI use the EMS to get to the hospital. 50% are still self-transported patients. In regards to pre-hospital ECG use, there was this increase from 2008 to 2011 in the use of pre-hospital ECG among EMS using patients. It increased from 47% to 55%. Overall, the ED bypass rate was about 10.5% among those patients who have STEMI and go directly to a PCI center. There was a small increase from 2008, where it was 8.5%, to 2011, where it was 11.5%. This graph shows the frequency of ED bypass by the time of day. It is clear here that during working hours, which was 7 in the morning to 6 at night, the frequency of ED bypass was 18.5%, whereas overnight or on weekends or on holidays, only 4.3% of such patients bypassed the ED, whereas 95% actually were evaluated in the ED before they went to the cath lab. This graph shows the distribution of ED bypass rate across hospitals. We can see there's a large variation across hospitals in the frequency of ED bypass. Overall, the median frequency of ED bypass on a hospital level was only 3.3%. And you can see majority of the hospitals, sorry about that, majority of the hospitals have an ED bypass rate that's less than 5%. However, it is also promising to see there are some hospitals that predominantly have ED bypass with the ED bypass rate greater than 50%. Although these numbers are very small, there's only 6 or 7 of these hospitals. Looking at our patient characteristics, out of the 12,500 patients, as I said, 10.5% bypassed the ED, which was 1,316 patients. The age of these patients was similar to patients who were evaluated in the ED, and the gender was the same as well. Prior myocardial infarction occurred more frequently in patients who were evaluated in the ED. And as you can see, patients who were evaluated in the ED were sicker than patients who were taken directly to the cath lab. Congestive heart failure was more prevalent, as well was cardiogenic shock. Non-system reasons for delay in PCI, which is a grab bag of cardiac arrest, intubation, and other things including tortuosity of the vessel or unable to wire the vessel during the procedure, was much higher in patients who were evaluated in the ED. Again, specifically, cardiac arrest and intubation prior to PCI occurred more frequently in this ED evaluation group. So this is the key results of my study. The two groups are represented by ED bypass and ED evaluation. The length of the bar is the median time from first medical contact to device activation. The 3 colors represents the time spent. In green represents pre-hospital, that is from EMS contact to arrival at the hospital. The yellow is time in the ED, and blue is time in the catheterization lab. And you can see that the median time, there's another number that's missing here. The median time among those patients who bypassed the ED was 68 minutes from first medical contact to device activation, whereas ED evaluation, the number should have been there, it's 88 minutes. That is a difference of 20 minutes in median time. The patients who bypassed the ED, 81% of them achieved device activation within 90 minutes, which was the guideline recommended time period, whereas among patients who were evaluated in the ED, only 54% meet the guideline time period of 90 minutes. You can see that ED contributes significantly to this delay in reperfusion, with a median of 31 minutes spent in the ED. When we speak to interventionalists and when we speak to emergency doctors, they always feel that patients make a small pit stop in the emergency department on the way to the cath lab, and only 5 minutes is spent. Apart from this, I did a survey of hospitals in North Carolina and looked at their practices in the ED for such patients. And majority of the hospitals still put in IVs in the emergency department. They repeat ECGs in the emergency department. Some hospitals still do chest x-rays before they're taken to the cath lab. Practices that would certainly delay time to reperfusion and may be unnecessary in this patient population. Oh, there it is. In regards to in-hospital mortality, the unadjusted rate for in-hospital mortality was significantly lower, 2.7% in the ED bypass group compared to 4.1% in the ED evaluation group. After adjustment for differences, which we noted on the previous slides, the in-hospital mortality rate was still lower, although statistically was not significant. Excluding the higher risk patients, those who were intubated or had cardiac arrest or had heart failure or cardiogenic shock, first medical contact to device activation was still lower with ED bypass, 67 minutes, a median time, compared to 86 minutes with ED evaluation. And you can see the first medical contact to device activation within 90 minutes was also more frequently achieved with ED bypass compared to ED evaluation. There was no difference in in-hospital mortality after adjustment, as previously seen. Again, this is an observational study which is subject to unmeasured confounding and bias. Specifically, there's some more information we would have liked from the database, which was not available, such as what were the reasons for delay in the emergency department? Was it actually the 31 minutes were spent as a delay, or was it because they were waiting for the cath lab to be ready to receive the patient? And what is the contribution of each of those? It's hard to separate from this study. We also are not sure what the process and timing of the cath lab activation is, whether the cath lab is activated en route to the hospital, or it's only done once the patient gets to the emergency department. We're also unsure what the distance is from the scene to the hospital and how long it takes to get to the hospital. The rates of false activation are certainly a concern, and rates of missed diagnosis are also a concern with ED bypass. In conclusion, ED bypass occurs infrequently in the United States and occurs predominantly during working hours. There is substantial variability in the use of ED bypass across hospitals. ED bypass is associated with significant reduction in reperfusion times with no adverse impact on mortality, and widespread evaluation and implementation of this process is warranted in the United States. I will spend just a few minutes to discuss the considerations for actually putting these protocols in hospital. And as we said, to be able to bypass the emergency department, you first need to have EMS pick up the patient rather than the patient transport themselves, and that rate is only 50% in the United States. And even among EMS transported patients, only 55% of patients are actually getting a pre-hospital electrocardiogram. So those processes need to be put into place before you can bypass the emergency department. Certainly, there are some patients who will always require to be resuscitated first in the emergency department, and those may be patients who need to be intubated or are going into recurrent cardiac arrest and need to be defibrillated before they come to the cath lab. Certainly, there's also a role to confirm the diagnosis and minimize false activation, although studies have shown that the false activation rate may be similar with well-trained paramedics and emergency department physicians, about 6% for calling an ECG as a ST elevation, although not intervening on the artery, the rates are much higher, about 20 to 25%. And certainly, as we said, that most of the bypass is happening during the daytime. At nighttime, most hospitals don't have a cath lab team that are in the hospital. So if the patient arrives to the cath lab before the cath lab team comes, there has to be a system in place where these patients are looked after by a holding team of in-house CCU nurse, CCU fellow, and a cardiologist until the cath lab team arrives, as well as have a process in place where the cath lab team is expected to start the case within 30 minutes of being paged. I thank you for your attention and happy to take any questions.
We'll take questions now and then also at the end of the presentation. So actually, there was a superb presentation, and obviously you have a list of things that one could do with this information. What do you think is the most important next step?
I think the next step is to get this data out to make the U.S. population aware and physicians aware that this practice is being done across the world, like we've been doing it in Canada and Europe. It is feasible in the United States. It's safe. And from the data that we have, which is the best data here, we can save about 20 minutes in terms of time to reperfusion. So once you get the information out, the next step will be how to build these protocols for hospitals. And there's a program called the Accelerator Program, which is funded by the American Heart Association in conjunction with industry, where Dr. Granger and Jollis are leading that, and where we're going across the country. We've taken 20 sites across the country where we go and educate how to build regional systems of STEMI care, and this is one of those things that you actually build into the system. Again, notwithstanding all the considerations I said, but certainly those have to be taken into account.
Good. Other questions, please?
In France, they have a system called, you must know, the SAMU, where they have doctors that actually go and get the patient and transport them and to the cath lab. So has this been evaluated, and is this something that is discussed in North America?
So just to repeat the question, so in France, a lot of the EMS, the ambulances are staffed with physicians. And that is one of the things that we don't have in the United States. And that is one of the concerns, whether a patient who has been diagnosed by a paramedic should go directly to the cath lab without any physician overseeing that process. So that does not happen in the United States, where a physician does that. That would certainly add a lot of resources in regards to putting a physician in the EMS system. But countries like Canada, where there is no physician in the ambulance, we still have ways where you can reduce the rate of false activation by paramedic training, or getting ECGs faxed over to the interventionalist or over the phone to confirm the diagnosis. So there's different ways you can address that without putting a physician in the ambulance.
Can you explain why there's such a low rate of use?
Yeah, I think it depends. So in the United States, the EMS, my understanding, and you can correct me, is by the Highway Control Act instead of actually public system. It's not universal, it's fractured. So there can be some regions that can have 500 different EMS agencies with all different protocols. Hospitals can own their private ambulances and send their own private ambulances in different areas. So there's a lot of different agencies in the United States, whereas a place like Holland, I would think it will be more central with central protocols. That's why it's hard to do.
If there are no further comments or questions, thank you, Akshay. And Connie, the floor is yours.
Great. So no mic, but I'm sort of quiet. I'll try to yell so you can hear me in the back. Thanks to everyone for such a great turnout for Akshay and my presentations. This was a project that I actually used for my master's in health sciences as part of the clinical research training program. And so I see a lot of faces of people that were involved in this effort. So thank you to all of you. Couldn't have been done without you. But we'll go ahead and start with a little bit of background. So many of you know that acute myocardial infarction, or AMI, is a common cause of hospital admissions in the US, and approximately 20% of patients actually return for readmission within 30 days of hospitalization for AMI. Now, AMI thus is a significant cost to Medicare and actually represented the 6th most expensive condition billed to Medicare in 2008. Understandably, CMS, or Centers for Medicare and Medicaid Services, has really expressed a keen interest in reducing these costly admissions. And one of the ways in which they've tried to do this is by implementing payment penalties for hospitals that have what they deem to be excessive readmission rates. The response to this obviously has then been a flurry of research and activity on the hospital system side to try to figure out ways to reduce these readmissions. And many of these strategies have actually focused on transitions of care processes. For example, one has been the idea of early physician follow-up after discharge. And in the heart failure population, data from Adrian Hernandez and Leslie Curtis here, among others, has shown that early physician follow-up is associated with reduced readmission rates. But whether this same strategy might be effective in the AMI population has not been studied. Therefore, we had two goals with this project. One was to characterize hospital variation in early physician follow-up visits after discharge for older patients admitted with non-ST segment elevation myocardial infarction, or NSTEMI. And two, to examine the relationship between hospital-level rates of early physician follow-up and risk of readmission in this patient population. Now, the project used two sources of data. The first you're all probably familiar with. I think Eric Peterson actually presented on what we've learned from Crusade last year, and this was a national quality improvement initiative based at the DCRI that was specifically including patients mainly with NSTEMI. And from the CRUSADE data, we were able to obtain very detailed information about patient characteristics, clinical presentation, hospital treatments, and events, et cetera. But an important limitation is that CRUSADE focused on in-hospital events, so we were not able to look at post-discharge outcomes. And to get at those, what we did was use CRUSADE data that were linked with longitudinal Medicare claims data between 2003 and 2006 for patients, obviously 65 years or older, cared for by Medicare, to look at these post-discharge outcomes. So because we're looking at a readmission outcome, we obviously limited our analysis to patients who survived to hospital discharge. We excluded patients who were transferred to other acute care facilities. Not all of them were CRUSADE participating, so we didn't have all the information on hospital treatments and outcomes. We also excluded patients transferred to skilled nursing facilities or to hospice. This particular set of patients has a very different readmission risk and may have access to facility-based physicians that could alter their likelihood of being readmitted. We excluded non-index admissions for patients who had multiple reports captured in CRUSADE, and only included hospitals with both PCI and CABG revascularization capabilities. The reason for this was to try to ensure a somewhat level playing field and similarity among hospitals included in our study. Finally, we excluded patients from low-volume hospitals to try to ensure stable estimates of early physician follow-up. And this ultimately left us with approximately 26,000 patients from 228 sites in our analysis. We defined early physician follow-up as a visit with an MD within 7 days of discharge after hospitalization. And this was mainly done because there was historical precedent. This was the time frame used in the heart failure paper. And so we wanted to look at this particular intervention in our population. And we defined our primary outcome as 30-day all-cause readmission. This was done for two reasons. One, because this is actually what the Medicare policy targets, all-cause readmission. Two, if you think about it, longer-term outcomes beyond 30 days may actually be unrelated to the index admission care. So, for example, if a patient has a lot of comorbid conditions, if you're hospitalized 60 days later, it may actually be related to another condition. There are factors like medication compliance and patient factors that may play a role. And also, there may have been interim care since your index hospitalization, and readmission could reflect that rather than the first hospitalization. So from a statistical standpoint, we used logistic generalized estimating equations to examine this relationship between hospital-level early follow-up and readmission. GEE was used to somewhat account for hospital clustering, and the idea was to examine variation due to differences between or among sites rather than just sampling variation. Now, importantly, we did choose to perform our analyses at the hospital level rather than the patient level. And this was done to avoid, or reduce rather, confounding by severity of illness. And what I mean by this is the idea that patients who are sicker are generally scheduled for follow-up sooner after discharge, but they also continue to be at higher risk of readmission from their severe disease. So our statistical models, we used 3 of them, and they were sequential adjustment models. The first incorporated patient demographic and clinical characteristics. The second had additional hospital features, for example, bed size, region, teaching status. And the third included additional treatment features of discharge medications, revascularization, et cetera. Now, shown here is the distribution of early physician follow-up across hospitals in our study. The median percentage of hospital-level early physician follow-up was 23.3%, but it did range from a low of 2.6% up to a high of 51.6%. And we looked at patient characteristics across quartiles of hospital-level early physician follow-up. The first quartile, or lowest, was defined as hospitals at which less than 17.8% of patients received early physician follow-up, whereas hospitals in the highest quartile had greater than 28.9% of patients receiving early physician follow-up. And when you look at the demographic characteristics, you'll notice that a higher proportion of Black patients were treated at hospitals with higher levels of early physician follow-up. From a clinical standpoint, patients treated at the upper quartiles of hospital-level follow-up had slightly greater burden of comorbidities, but did present more often with signs of heart failure and were less likely to be transferred in. They also were less likely to undergo revascularization procedures, all of which probably points to this patient population as being slightly sicker. When we looked at hospital characteristics, you'll notice that hospitals in the West region happen to have higher levels of early physician follow-up, but we should also note that we had the fewest number of hospitals from the West participating. And other characteristics, teaching hospital bed size, were similar when we talked about the transfer status. So overall, 18.5% of patients were readmitted within 30 days after discharge, but these readmission rates didn't really vary across quartile of early hospital physician follow-up. When we looked at risk-adjusted 30-day readmission, again, for all of these models, the first quartile or lowest quartile of hospital follow-up was used as the reference group. And in our first model, after adjusting for patient characteristics, we found that all of the confidence intervals crossed the line of unity, indicating no significant association between hospital-level early physician follow-up and 30-day readmission. We obtained similar results when we adjusted for hospital features in Model 2 and additionally treatment features in Model 3. Now, because of this negative result, we really wanted to think hard about whether there were certain subgroups that actually might benefit from early physician follow-up. This was a result that was different than what they found in the heart failure population. So first, we decided to look at the high-risk group. We used the GRACE, or Global Registry of Acute Coronary Events, risk score for 6-month post-discharge mortality to define our high-risk group, and that was defined as a 10% or greater predicted mortality. A third of our cohort met this definition, and when you look at just sort of a smattering of the clinical characteristics, you do see that they are a sicker group of patients, so they are different. As expected, the higher risk patients did have a higher rate of 30-day readmission. However, when we looked at in our models, there was still no association between early physician follow-up and 30-day readmission. So next we moved on and said, well, what about looking specifically at cardiovascular readmission, not just all-cause? We defined our CV readmissions using diagnosis-related group codes from billing data. And overall, 13.2% of patients were readmitted for a cardiovascular diagnosis. Now, if you take this as a percentage of all the readmissions, this makes up about a third. So a third of patients are readmitted for a CV diagnosis. But again, no association between early physician follow-up and readmission. And last, we looked at, well, what if someone sees a cardiologist specifically for follow-up, not just any physician, not a PCP, et cetera. Well, the median hospital level early follow-up with a cardiologist was 5.6%, and again, nothing. So we see a same pattern here for all of our attempts. Now, obviously, there are some important limitations that we should recognize here. It's an observational study, and as always, there is the possibility of residual confounding. We did limit our population to Medicare beneficiaries, and although this may mean that our results are not generalizable to the sort of general population of younger patients, I think the Medicare population makes up a significant portion of AMI patients, and with their age and other comorbid conditions generally are at higher risk. So I think this still is an important population to study. We didn't have data regarding non-physician post-discharge outpatient visits. I think it's clear that this could, seeing someone who wasn't a physician might actually change your readmission risk, a nurse practitioner, other healthcare providers. So that is something we need to acknowledge. And finally, it's just possible that the hospital level measure may be too insensitive to detect a true association between early physician follow-up and readmission. We did have low overall rates of early follow-up, and perhaps there wasn't enough variation. That being said, from these data, we do conclude that 1 in 5 patients admitted for NSTEMI is readmitted within 30 days after discharge. Most patients are not seen in follow-up by a physician within 7 days, and overall hospital rates of early physician follow-up are low but variable. Despite this, we demonstrated no association between early physician follow-up at the hospital level and 30-day readmission. Future directions are probably a number, but I think they include prospective assessment of early physician follow-up and readmission, examination of other strategies to try to reduce readmissions, and potentially looking at early follow-up as part of a bundled strategy rather than just an isolated intervention. So thank you for your attention. I'm happy to take any questions.
That was superb, and I know that there have been recent literature, and there's a paper in circulation in the last couple of months that looked at cardiologists specifically and the follow-up strategy as compared with non-cardiologists and perhaps having an effect on readmissions. Do you think that this was limitation of the number of patients, or that there are some other limitations that we need to get beyond to answer the question more specifically?
Well, I think it's the number question is always there. I think it's certainly a possibility. As you see, we only had 5.6% as a median level. So again, there may not have been really enough variation. I think it also probably may depend on what patient population you're looking at. So, you know, the heart failure population with a very chronic, tenuous condition where you've had diuretic regimens adjusted and a lot of medication changes may actually just be at higher risk of readmission and may benefit from seeing a physician early to say, let's go over your meds, let's make sure you're taking your Lasix correctly, et cetera. Whereas the MI population may have a different risk profile because, you know, you've had potentially your revascularization, you have a set medication list that's not being changed daily by your own judgment. And so I think there's a lot of different moving pieces that may explain why you see an effect in one population or another. And
yeah, the first thing that comes to mind is that the ST segment, the non-ST elevation
heterogeneous.
group is such a heterogeneous group.
Absolutely.
Some of them have obstructive coronary disease, some of them have heart failure, some have a combination of both. But what do you think about the calls? I know at Duke Hospital right now that for a diagnosis of ACS, that patients are getting calls through the heart center, typically within 48 to 72 hours of hospital discharge. I think the patients love it. Are there data to suggest that has an impact on rehospitalization? Certainly patient and family satisfaction is important. What are your thoughts there?
So specifically in the cardiovascular population, there has not been data necessarily that I'm aware of looking at that, but they have looked in other populations. So there's data from just sort of general medicine service discharge patients that show that that actually is helpful. So I think one of them actually specifically had a pharmacist calling 48 hours to 72 hours after just to go over your medication lists. And these are all you know, they've had discharge planning systems in place where this is one of multiple strategies that have been shown to be effective in the COPD population, for example. So again, I think there's a lot of value to it, as you said, even from patient and family satisfaction. And certainly that might actually be a more cost-effective means of, you know, a phone call versus a physician visit. So I think some of that, you know, indiscriminate use of any of these strategies may not be the answer, but trying to identify the best population that could benefit might be the key.
Eric, thoughts? I mean, obviously this is an area of not just interest, but expertise.
Yeah, I guess if I try to put Akshay's and Connie's studies in context together with one another, I think they're both remarkably interesting. If you look at it, partly we're studying the existing system we have and figuring out how to optimize it for various things. Optimizing for early treatment, optimizing it for reducing readmission. Each of them went into it with a theory that something would be good. One of them, if we skip the ER or ED, it would be good for patient care. We could speed it up and it would be safe. And lo and behold, it seemed to pan out pretty well. Connie went into it with the theory that if we saw early physician follow-up, we would see benefit. Connie wasn't right. So something similar, something different now. But there's a flip of this is to say maybe moving forward we would sometimes take this from the other way. Is out there sometimes we hear great models be done in a different country, or in ours. We could look directly at that service, or we could flip it around and say, we could look at the outcome. Which hospitals are doing remarkably well with readmission, or who were bad but get remarkably better at readmission, and then try to better understand what it was that changed between A and B, to better identify what it is that are those unique processes. Here we might have not been right, or maybe we just were not sensitive for it. But there may be other tricks, like the telephone calls or other things that are out there that we can better target understand.
One would only hope if CMS is going to offer incentives or penalties that it's based on some very, very strong and convincing data. You had a question?
That was a great talk. Based on your data and what you've read so far, to what extent should hospitals be blamed for readmissions?
So, Tarek, that's a loaded question, and that's actually probably the topic of a 10-hour discussion itself. That actually is probably you've put your finger on one of the key controversies I think over this. As I mentioned, I did allude to the fact that I think a lot of readmissions are due to factors that are beyond the hospital's control. Patient compliance with medications. Hospitals can't do anything about that. Patient socioeconomic status, so whether you can go to cardiac rehab, whether you can afford copays. I mean, all these things I think are related and beyond control. So I'm not sure that readmission is necessarily a fair performance measure as it's currently being implemented. I think right now, the reality is it's in place. So we sort of have to try to figure out ways to improve these measures. But there was actually a recent editorial by Karen Joint and Ashish Jha sort of stating that a couple of the things that are not taken into account when applying these risk standardized readmission algorithms is one, mortality. So there's sort of this inverse relationship between readmission and mortality. If you have a lot of your patients die, then they're not going to be readmitted. Great, but that's clearly not the way we want to be going with this. I think the second issue is the socioeconomic status. When they went into this, Medicare thought that I think about 5% of hospitals would be subject to payment penalties. Looking at the most recent data, this sort of first initial look, it's I think about 2/3 of hospitals actually qualify, which is a lot higher than they expected. And when they looked at which hospitals that were getting penalized, it was actually the safety net hospitals, so hospitals serving indigent populations with low, sort of poor resources, and also larger teaching hospitals, which may just reflect more complicated patients. And so I think it's possible that the current algorithm for applying these penalties may exacerbate disparities, and I think that's part of the issue here. I don't have a great answer, but I do think people are looking into it. So.
Obviously, it's important as more resources are being put into same-day hospitals and same-day clinics, and that may work very, very well for heart failure, where there's a national average of 23 to 24% readmission. But the non-ST elevation myocardial infarction group is, as Connie has said, is heterogeneous, and a little bit more data are required before a hospital system puts a lot of resources into it, or CMS continues to penalize teaching hospitals and those that care for the indigent population at risk. So, if there are no further comments or questions, I'll ask Akshay to come up, and Connie, and I've just asked them to spend a moment talking a little bit, as you can see, I didn't give them any clear warning, about the DCRI Fellows experience, so it could be captured for perpetuity.
Great. Yeah, so that's funny you mentioned that. I actually considered just, instead of you hearing me speak about all of this, just hitting play and having the DCRI Fellows video go, but I thought that would be frowned upon in general. You can feel free to, it's, sure, if for recording purposes.
Okay. Well, I think we shared some of our feelings at the end of the year fellows dinner, but certainly want to state them again. It's I speak, I think, for both Connie and myself. It's been a pleasure to be the representatives of the fellows over the last year. We've had a great time working with all the fellows and the faculty. There's a number of people to thank. This fellowship would not be possible without the support from the director, support from Matt Rowe, Renato, Brian, and Patsy. Everyone does a fantastic job. And I don't think if all the fellows fully appreciate how much time they actually spend to be able to put this fellowship together, and how many phone calls and meetings they have, and how many ideas that Connie and I have come to them with, and they discuss and take the moment to actually say, okay, how can we actually organize these things for the fellows and make their experience better? So on behalf of all the fellows, certainly like to thank all these people for taking the time and making our experience here amazing. Thank you very much. Second, I think there's a number of people that the fellows interact with, not just the faculty here, but the operations people, statistics, data management, stuff that I had no clue about before I came here, and the stuff that I've learned over the last 2 years of working with you and learning from you. And I certainly like to thank all of you for teaching me all of that. And hopefully I've given you some back and taught you some cardiology over the last 2 years. But it's been a two-way street. And certainly I've learned a lot, and lots of friendships I'm going to take back with me. And when I say that about myself, I'm sure all the fellows feel the same way. So again, on behalf of Connie and myself, thank you all for making the fellowship experience a great one.
Thanks. So some of what I thought about saying will obviously echo Akshay's experience, but I guess just to give you all a little bit of background, my training was in basic science. So before coming here, I had no idea what any of you guys did. I obviously knew about the DCRI. I was at Harvard, so I knew about the TIMI group, and I knew about clinical research. I read about it, but I really had no concept of what went on behind the scenes. And when I came down to Duke, I still was actually basic science oriented. Somewhere along the way, I changed trajectory and saw the light, as if you will. And when I first came here for that, first of 2 years of research, I was pretty overwhelmed. Anxious, and even when Matt asked if I would be a chief fellow, I was still a little bit apprehensive, thinking, "Oh, do I know enough? Should I really do this?" And I have to tell you that my experience has, as Akshay said, been so positive here. From day one, everyone that I met, outcomes, operations, CEC, you all have really been so welcoming. The faculty, so busy, but yet so approachable. Everyone has been welcoming. You've entertained all stupid questions and really been enthusiastic about teaching the fellows. Everyone that I've talked to has said, no, we love working with the fellows. And, we fellows all love working with you, and I think it's really true. My experience here has shown that, as many people say, the DCRI just can't be replicated. It's really unique. I've been really honored to be here. I think Akshay has as well, coming from Canada, and we'll really take a lot of what we've learned and really hope to continue our relationships with all of you. Again, not just all of you sitting here, but the fellows. The fellows themselves are a really incredible group of talented and diverse people who have also taught me a lot and taught Akshay a lot. So thank you to everyone, and we hope we will continue to collaborate.